this is really an interesting approach to the issue, to the problem, to go with economic cost-benefit analysis, because really we often do not consider it when we are introducing novel and sophisticated devices. But if you do so, it's because there is a benefit, and it should come even into costs. So from the floor, they are asking, how long did it take you to complete such a cost-benefit analysis?
Mm-hmm. Well, I got a lot of help from Stefan Ebiter. So, but I would say it takes about 1 or 2 workdays, but because you have to schedule in, well, more than one meeting where you get together and put together all the information, and then you have to go to your controlling and then ask for the information, which is sometimes quite stressful, but it's worth the pain.
Yes, now I understand. You were very fast, actually. 1 to 2 working days means 16
hours. Combined.
Split. So I assume, yes, in different days. I'm trying to do this. I'm a little bit late.
Yeah, maybe the time I saved using CAS One for that year.
Yes, that one, exactly. So that's a question from the floor.
One question. Lukas, really excellent talk and excellent. That's a business case, what you made. So I think we need exactly this for every new technology we want to implement in our clinical work, even though there is no clear reimbursement for this. So you made clear this very, very good. My question is, how long is the learning curve to be, to get a really efficient clinical workflow? How many cases do you have to do that you return the investment?
As a clinician, I would say it's maybe 10 to 20 procedures you have to do until you're really familiar with handling the aiming device and everything and setting everything up. I think for the technicians, it's a little bit easier. If you have someone who is interested in doing stereotactic navigation and who is open to change, it might be 5 to 10 ablations until they're really familiar with the setup, and from then on you can work really efficiently. But it might take 10 to 20 ablations approximately. I'm not really sure what the others think about that, but it's just my feeling.
Yeah, I think that's right.
Can you come to the microphone, please? Or here, or... Thank you. I think also the frequency of the treatment is very important, not to pass 1 month between one and the other, I think.
That's right, yeah. I mean, for us, it was about 5 to 10 cases. I showed that first case, which was fusion. Our 4th case or our 6th case was a patient with 7 tumors in bilobar disease, and, that was fine. So.
And for sure, for the first cases, there is the complete support of the team, of cascination team for doing them. Any other question from the floor? So was it easy to convince your hospital manager? How did you manage with that? I'm really interested in that.
It wasn't this easy, but we had the big advantage that we did have cascination for quite a long time before we were actually able to buy the system, because I think we were one of the first adapters in Germany. It's been quite a dynamic situation because of that, and we did profit from that a lot, because we didn't have to show the hospital anymore that we are doing good work with using the system. So it was quite, well, maybe not a situation that many of you will have once you try to get your hands on a system. We were very lucky because we were one of the first ones in Germany using the system.
But what you told us, and it's very useful advice, is to take into consideration that anyway surgeons are using other, I would say, similar at large devices. So we do not have to be shy to ask, because they have, for example, the Da Vinci robot that is really, really very expensive for the consumable, for all the things. So bear in mind that we are treating cancer patients. We want to have the best result as possible for them, and if technology can help, we have to provide them the numbers as you have done with the cost-benefit analysis, but we have the right. We should go on very, very strong with that. We have the right to have the best available technology to obtain the best results as the surgeon do. So we are not less important than they are, especially when we come to treat their complications. That happens very frequently. So reducing the number of surgical complications coming from resection and complex hepatectomies or preserving parenchyma surgery that they are doing is also another important point in the cost-benefit analysis.
Yes, and you don't have to be competitive to the surgeons completely, so because they can profit from your success as well. If you bridge patients to transplantability, for example, that's a big win for the surgeons. Or if you treat lesions that are in the left liver lobe close to the heart using cascination successfully, and they perform right hepatectomy for the rest of the tumor lesions. I think that's a win situation for the surgeons as well, so you can get them on board.
Yes, for sure. That's a good advice too. So are there any other questions? Yes, please.
Well, I think I'd like to ask the presenters, because of their large experience, the specific issues about lesions close to the heart, subcapsular lesion near the heart, any problems that arrhythmia. These are lesions that often we recommend different therapies because we are afraid of burning subcapsular lesion near the coronary arteries. Any problems on that?
Well, I can just talk for Ringsburg, and we didn't experience one single complication with that specific aspect. And as Maria already mentioned, for us, tumor location is not of real importance anymore.
We have done many of those cases. As I said, we get referrals from other parts of Sweden, and we have not had any complication from the heart. I think the heart is so well, all the blood running through the heart will keep the temperature down, so you don't need to worry about the heat for the heart. We have had quite a few, or not quite a few, but a few hernias after maybe diaphragmal hernias, after maybe 1 to 2 years after ablation. And that is a complication, but we consider it to be a minor complication because usually the patient doesn't even know about it. We just see it on the CT follow-up. So it doesn't stop us from doing those types of ablations.
Less power or shorter time if it's near the heart? No.
No, the heart can refrigerate himself because of the flow. The problem is if you directly puncture a coronary, that may happen. It has been described in the literature, but it's really a very rare complication. And those systems like CAS One are those that help us to prevent exactly those kind of complications. So.